Hey guys, welcome to our podcast here. This is kind of a new thing for us here at TOA in East Tennessee. My name is Dr. Justin Kennon. I'm a shoulder surgeon here in Knoxville. I see patients in Bearden and Park West and Oak Ridge. I've got Landon Prather. He's my physician associate, part of our shoulder team here in East Tennessee. We kind of were asked to give an update. We're going to talk a little bit about advances and non-operative as well as operative shoulder stuff today, and just kind of talk through how we approach patients and how we try to get patients feeling better and back in the game. So we hope this will all be kind of entertaining. So, Landon, I guess what I was thinking here, buddy, is you and I see a lot of patients. We take care of a lot of shoulder pain.
For sure.
For patients, young athletes, kind of middle-aged, what we call the weekend warrior, so to speak. And then also a whole lot of folks in their 60s, 70s, 80s, 90s even that have developed advanced shoulder arthritis or just have shoulder pain that's limiting them from enjoying time with their families, playing with their kids and their grandkids, even being able to do things like open, I guess, simple stuff, right? Open a medication thing, being able to get things out of a cabinet, just basic life stuff that fortunately you and I don't have to think about our shoulders too often. Landon again is our non-operative guy here. So I want him to kind of tell me how you kind of approach a new patient and kind of talking about non-operative stuff. Because obviously, even as myself as a shoulder surgeon, I have no desire to ever go through shoulder surgery if I don't have to.
Sure.
So I think we try always to keep patients out of the operating room if we can.
Right.
So tell us a little bit about that and how you approach a new patient.
So my main approach looking at a new patient with shoulder pain on a non-operative level is thinking about injection therapy, medications we might be able to give them, formal physical therapy. What things can we offer these people to keep them off an operating room table? And
Sure.
At the same time, it's also a thought of, is that appropriate? Looking at their imaging, does that injection, does that physical therapy, does that treatment plan match how severe their problem is? Because there's certainly people out there with advanced shoulder arthritis that we know that maybe physical therapy is not going to help them because they're eroded into the glenoid and they've got terrible deformity and maybe it is surgical. But for the folks that have maybe moderate osteoarthritis or my partial thickness rotator cuff tear, they might be a good candidate for a steroid injection or PRP injection, or maybe an over-the-counter or prescription strength anti-inflammatory, and work with a physical therapist. And maybe that's something that we could offer that patient that would keep them from having to be in a sling for 6 weeks and non-weight bearing for months and months. And there's a lot of patients that are pretty driven, especially around this time of year as the fishing seasons get underway and summer vacations come along, that maybe I can give you an option that get you through the summer, and then you can get your shoulder surgery done in the winter.
Yeah, for sure. I mean, I've had a lot of patients recently. They know what the end goal here is. They know, hey, this fall I'm going to need to have my shoulder replaced. But they just want some time, right? They want
Sure.
something that's going to buy them some time. So that's a great point. Trying to find options, and everybody's familiar with kind of steroid shots, but you brought up which we do those. That's obviously an option for a lot of patients, but you brought up a great point. Outside of the steroid world, because they have some downsides.
Sure, they do.
If you're doing them over and over and over. So if you're trying to buy yourself time, you mentioned a good one. You mentioned PRP, which I know is a little bit kind of a newer, more holistic approach. Tell me a little bit more about that and who you think maybe is a good candidate, and a little bit about the process.
So PRP is a newer biologic injection that we do, where we take a patient's blood and we draw it here in the clinic. And we put it actually in this machine here, which is a centrifuge that spins that blood and takes some blood products out of it that are pretty valuable to healing and as an anti-inflammatory effect. So PRP is platelet-rich plasma. It's a very high concentration of platelets, but also a lot of growth factors and cytokines, which play a key role in our immune system and a key role in our inflammatory response.
So that can help patients actually have less pain?
Yes, it helps patients have less pain, but it's also nice because it does not degenerate tissues like repetitive steroid injections can do.
Yeah.
And a nice part about that too with surgical planning is With steroids, we have to wait about 3 months usually after a steroid injection to operate on the joint that we inject. Whereas PRP, we can operate at any point in time after that injection. There's no increased risk for post-operative infection with with PRP injections versus a steroid injection. I think that's a huge advantage.
Yeah, because 3 months that's a long time for some patients, right?
Sure.
The other thing you hit on there, you kind of mentioned the PRP as a non-operative option. But what's also interesting, and you tell me kind of what your thoughts are, but as a surgeon, right, I'm also utilizing PRP in the operating room
For sure.
To augment kind of what we do. Patients that fail conservative care, but end up in the operating room where we do need to do a procedure, help take care of a rotator cuff problem or a shoulder arthroplasty, shoulder replacement, something of that nature.
Sure.
But the PRP, it kind of has a role here in the operative setting as well, correct?
Correct. Yes. So they have done. There's one pretty decent study that showed a reduction in re-tear rate for rotator cuff repair when they injected the rotator cuff after fixing it in the operating room. But it's also a nice tool that we use for its anti-inflammatory effects post-operatively to reduce post-op pain.
No doubt.
And that can be a lot longer lasting effect than a steroid, which is also nice.
Yeah, for sure.
Both in the clinical setting and the operative setting, where we're seeing some results with these injections that last, instead of a steroid shot that might last 3 or 4 months, we might get up to 12 months out of a PRP injection.
Yeah, that's great. So again, I mean, you have the non-operative side of it, but then the operative side, I remember we had a patient with just a huge, really large, massive rotator cuff tear, very active guy, I believe late 50s, early 60s, but really active. And, we were talking with him and he was adamant. I mean, he had done his homework. He had read about PRP. He understood that there's some out-of-pocket cost with that. And he said, look, I could care less. He said, look, this is my shoulder and this is my one chance at getting back. He was a guy, remember, he's a farmer, right? So he was trying to get back to taking care of the farm. And he still to this day, if you ask him what made the biggest benefit in his recovery, he would probably say the PRP.
100%.
I'm biased and I'd like to say it was my excellent surgical technique, right? But the truth is it's probably a combination of both.
Sure.
We use a lot of really advanced and newer technology in surgery, which I do think is very beneficial. And it's a huge, huge, huge improvement from where we were even 5 or 10 years ago in the operating room. But again, being able to augment that afterward with regenerative medicine and that type of thing, again, is just huge because, again, you're committing months, weeks and months of your life to this recovery. You want to maximize the chances that it's going to work.
Absolutely.
And decrease your chances of ever needing to be back in that operating room, right? I mean, listen, I get it. I'm the surgeon, but I have no desire. I mean, none of us want to go through this if we don't have to. And so, I think that's a great point. We've really seen some good success with it, and we have a lot of patient testimonials and patients that just have really done well with it. I think that probably leads us to kind of a good natural segue talking about operative stuff. We talked about the advances with PRP. Another great non-operative thing just before we jump is, the ultrasound use, right, that you've done. So I know you did some additional training in ultrasound and biologic training. You're one of the only guys I think around that's doing all that. So tell us a little bit about that before we jump to
So I think
stuff.
the most important takeaway that I got from the training that I underwent back in January is PRP, unlike a steroid, is very location specific. So a steroid injection, it works more as a hormone. So if you get it close to the joint, they've had some studies that show it still kind of works. Yeah. Whereas PRP is specific to the structure that you're placing it in. So if you have a partial thickness cuff tear, you need to get that PRP into that partial thickness cuff tear.
Sure.
Or if you are treating osteoarthritis, you need to make sure you're in the intra-articular or in the joint space with that product, because if you don't get there, it does not work as well. So you have to be on spot. So using ultrasound guidance to get there confirms for me and confirms for the patient that we did the right thing and got the injection in the place that we needed to.
Right. Yeah, that's a good point. And again, nothing works for everybody, right? Nothing in medicine is 100% or 0%. But I think increasing the precision of which where you put the medicine makes common sense. You don't have to
100%.
be a shoulder surgeon or a
understand that.
brainiac to understand that works, right? You got to put
sure.
the medicine where it needs to go. So yeah, and truthfully, I'll be honest, I've seen you do it, and you're a lot better than the rest of us at it. So I'm glad to have you on the team and helping treat a lot of these patients and trying to keep them out of the operating room. Shifting gears a little bit, I guess, unfortunately, you and I do end up having to take a lot of patients to the procedure area.
Mm-hmm.
And I guess as an intro, one of the common, I guess, myths that we hear and kind of, I would say it's a bad rumor out there it's propagated that I think it's a good community education point, is that we have patients all the time that come to us that are completely misinformed, I think, about what shoulder surgery and shoulder recovery looks like.
Oh, for sure.
And so, I guess, I would argue one of the biggest things we do in shoulder surgery, and what we do a lot of, as much as probably anybody, if not more than anybody in East Tennessee, is shoulder replacement, right? And so shoulder replacement's had a lot of technology advances over the past 10 years, 5-10 years. And, a big difference now compared to before is that, this is primarily an outpatient surgery. It's the largest shoulder surgery we do for the most part. And it's something that's a 1-hour surgery that 95% of my patients go home the same day.
Yeah.
We have a, state-of-the-art surgery center where we're able to do this as an outpatient, 1-hour surgery, minimal blood loss, kind of minimally invasive, and patients are in and out within a handful of hours and they're back home recovering by lunch, right? I mean, that's not the way this was 5 or 10 years ago. So I think there's some misconceptions out there. And I think the most common reason is that I hear this from patients is they know people that had surgery done by someone else or somewhere else in town 5 or 10 years ago. And that's the way it was. And the truth is, it's still how it is in a lot of the community. And so they are staying inpatient and they are staying for days and days in the hospital. And obviously there are patient needs sometimes where we do need to do things at the hospital. That's fine. But even patients that are done in the hospital, it's still about a 1-hour surgery and they still go home the same day, a lot of them.
100%.
So if you have a 90 or 95% chance of going home the same day, you're decreasing your infection risk, you're decreasing cost to you and to the insurance companies and the whole overall health system, right?
Yeah.
I mean, if you're really sick, you need to be in the hospital. But if you're not sick, let's get your little procedure done and let you go home, right? And recover at the house. Not to mention, typically speaking, you're going to have a loved one or a friend or a family member or a church member or somebody that's going to help you out. And truthfully, they care probably a lot more about you than a nurse that's got a million other things to take care of, right? And so we love our nurses and our staffing, but at the same time, nobody's going to care for you more than your loved one, right? And so trying to get you home. I just think recovery goes better, and we know the infection rate's lower. So a lot of benefits to doing these at the surgery center and even as an outpatient at the hospital. So I think that's a big, important one to know. But then I guess at a higher level, you say, well, what else is new and why are things so different? Well, I guess the big point for me and where it really struck a tune with me was, when I was a shoulder surgeon at Mayo Clinic before I came here, right? And so I came back to Knoxville and kind of restarted things here. But when I was a shoulder surgeon at Mayo Clinic, I realized that, man, the world is much bigger than what we have here in East Tennessee. And, I came back to East Tennessee for a reason, right? I've been here, 6-7 years now back here. And I came back because, listen, as much as I love technology on a day-to-day basis, I'd much rather be fishing or play golf and be outdoors, right? I don't want to be behind
in Minnesota.
That's right. I do not want to be behind the computer screen, right? But at the same time, you have to acknowledge that technology, has a huge role. Thinking about AI, thinking about all the advances we have now, for us to think that doesn't play a role in surgery and in patients' recoveries is crazy, right?
Yeah,
it's ludicrous.
Sure.
I always tell patients. I don't even have my cell phone on me. That tells you how, advanced we are. But, I tell patients, think about the phone that you had 15 years ago. What was your phone like 15, 20 years ago, Landon?
Yeah, it was flipped open, couldn't get on the internet.
Yeah. And really for a lot of our patients, even our 70, 80-year-old patients, if you ask them 15 years ago, they didn't have a cell phone.
Yeah,
and
probably
they were
not.
adamant they would never have a cell phone,
That's true.
right? Their phones were on the wall with a cord on them, right? Or it looked like the Zach Morris phone. You remember those, big, huge ones, right? And they carried those around, right? And when you got too far from the base, it would buzz at you. You're too far away, right? So that's what a telephone was 15, 20 years ago, right? There were payphones. You're probably too young to remember that, Landon, but
vaguely.
There were payphones, right? So now everybody has not just a phone in their pocket and in their hand. It's a high-speed computer doing everything, right? It's a microprocessor doing a gazillion things at once. So we all acknowledge that. That's something that's very relatable for everybody. But to then think that we don't have advances in shoulder surgery technology, and we say, oh, well, we've been doing it the same way for 15 years, that just makes us sound very antiquated, right? We're very old school, right? If you're thinking like that. So as much as I'd rather be fishing or outdoors hiking or doing something here, the truth is technology and computers are an important part of what we're doing in the OR. And so I guess when we talk about what's new, I kind of think of things, a lot of it has to do with advanced imaging, right? So all of our patients, or I guess tell me, Landon, when you see a new patient, you're thinking maybe they do need a shoulder surgery or shoulder replacement, something like that. What are kind of the workup steps that you go through in terms of imaging and type of thing to help us get a better idea of what they might need?
I think the first things first is an X-ray, right? You got to diagnose it. And once you notice that someone has osteoarthritis, there's kind of two major questions for us as a surgical team thinking about, all right, how do we replace this patient's shoulder? What type of implants do we use?
They're bone on bone.
Yeah, bone on bone. And I think the first question is their rotator cuff intact? And so an MRI is a pretty important piece of that. And then the other question is how deformed are their bones?
Yeah.
And so that's where I think the 3D CT scan that we order with Biomet protocol, I think is a big part of that as well, as far as advanced imaging that we need to obtain, not only for us to look at and determine, how much bone loss there is, but also for our 3D models that we use intraoperatively in our drill guides, and also for your pre-surgical planning that you do on the computer. We couldn't do that without the 3D CT scan.
For sure.
I think it's super important.
Yeah, a great analogy, I think, is, if the tires are worn off the car, right, and and you continue to drive on those tires, they're getting flatter or more bald, right? The tread's wearing away. Well, once the rubber's off the tire, if you continue to drive, right, then what happens is the rim starts getting deformed, right? Because you're just clunking along. Well, it's amazing that we have patients that live with that much shoulder pain for years and years and refuse to get it fixed, but they do, and we see that. So when you're deforming the joint and the bone is being worn away, you can't always see all that on an x-ray, right?
For sure.
So that's where we usually get this advanced imaging. One of the things you were talking about, we have a model here. So all of our patients end up getting a kind of a custom shoulder is what I call it, right? So everybody ends up getting a 3D printed model of their shoulder. So it's not Dr. Kennon's shoulder. It's not Landon Prather's shoulder. It's unique to every patient. Once we get that 3D model, and I mean, literally it's 3D printed, right? So this is the socket. And then they give us, models of the balls. Before we ever get to the operating room, I can check range of motion, functionality. I can do all that. I can dial things in within a half of a degree of accuracy. Well, how did we, before that, it was this, right? It was the old,
that looks pretty good.
Looks pretty good, right? Yeah, that's what we did, right? It's kind of like, again, I brought up fishing, but it's like when you're fishing, you're like, look, the fish aren't biting here. We'll try another lure, right? I mean, it's just a guessing. Let's see how it goes, right? So same thing here. That's how we used to do it. So now when we have this precision and we get everything custom made and printed for each patient, these guides, they fit in perfectly, helps us put the implants exactly where they need to go. But you got to know what you're working with before, right? So that's where the imaging comes in place. And so after you get the imaging and you've kind of talked about, the types of replacements, again, you mentioned it. So again, with a healthy rotator cuff, tell us about what the patient's options or what you're thinking they might be a candidate for versus what they're not.
So for
what the alternative is, maybe.
For a healthy rotator cuff with osteoarthritis, I think first line treatment options are always a consideration with steroid injection.
Yep.
Is always a consideration. PRP injections pending how severe their osteoarthritis is. I don't think giving every patient that comes to the doors PRP, it's not like it's magic juice that's just going to heal everybody. But I think if you have mild to moderate disease, PRP may be a good option. But if you have severe disease, I think at that point it's time to consider possible shoulder arthroplasty.
Yeah.
And so that's at that point, that's when you're ordering the CT scans, maybe an MRI to confirm that you don't have a cuff tear so that you're planning. And one thing I think that's super valuable that, I've worked with other shoulder surgeons in the past that I like with you with doing the 3D planning is a lot of times before a case, you come up to me and we're talking about, what we're about to go into, and you've already seen this patient's anatomy and you know what you're getting yourself into before you walk into that room. And we're kind of already knowing, what tissue do I need to release to better see this glenoid that's looking towards the back? Or, you always have a plan going in because we already have the imaging and you've already kind of performed the surgery on your computer before we even start the day.
For sure. Yeah, no doubt. And then also understanding that we use a variety of technology and a variety of implants. So it's not a one size fits all approach, right? So if it's, this other big, I guess, misnomer, right, or miscommunication out there, or this urban legend, that I'd love to dispel is, I see a lot of patients that have had shoulder replacement done elsewhere, and the implants they use are enormous, right? It's very invasive. They have long stems, they're this long going halfway down to their elbow or almost to their elbow. And the idea that's state of the art is just baffles me, right? So, the implants we use now, and again, when I was at Mayo Clinic, I realized, listen, I'm with the best shoulder guys here in the world, literally the best guys in the world. And when I go back to East Tennessee, it's crazy for us not to push the envelope and help people recognize there's something better out there.
100%.
And so now, we use these little implants, like there's no, there's no stem, right? It's this itty bitty little implant here. There's nothing down here. Previously, that stem would still be down here, right? And so much less blood loss, much less pain, much better. Say you're in a bad situation where something doesn't work, right? And we have to go back and revise it, right? So you've got a traditional shoulder replacement. It's done well for you. Say you have a trip and fall, right? You fall 10 years later, you tear your rotator cuff. Now you got to get a reverse put in, right? Reverse is a great option. It's a wonderful surgery, but it's not what everybody needs. But say you need that, right? Say you've had one of these done with minimally invasive techniques, with less blood loss and, all this. Listen, I can pop that out. This is the stem we use for reverse now. Look at how little that is, right?
For sure.
Previously, these things were down here and they're that big, right? And so being able to put these itty bitty stems in really is a hardware improvement and from a technology standpoint, but much better for patient care and patient outcomes and recovery and all that.
I think the amount of trauma that you cause taking out that implant versus a big stem is way less just on even just the soft tissues.
For sure. Yeah. And so the recovery is easier, right?
100%.
So that's why for a lot of our patients, if you come in, say you don't have a horrible complex problem, you've just got bad arthritis, maybe cuff problem, and you end up with a shoulder replacement, you're in a sling for 2, maybe 3 weeks. It's not 6 or 8 weeks like people kind of used to think it was, right? So again, you're talking about an hour surgery, you're outpatient, you're out of the sling in a couple of weeks and you're using your arm, you're back to taking care of yourself. You don't need 24-hour care for weeks and weeks and weeks. It's just very different. So again, I guess kind of shifting gears just a touch, but again, talking about what's new out there. Again, I think minimally invasive approaches, a lot less trauma to the soft tissues and the bone, implants that are convertible, right? So again, you've got these custom implants that are made that literally fit, again, perfectly, right? So it's custom made, fits right in there. We use these things custom for each patient. And then what happens is you go, well, what happens if something doesn't work on one side or the other? Well, a lot of these, instead of having to rip things out of the bone, you just pop one piece off and put another one in. Yeah. It's kind of like, Legos, right? Or something, right? You pop one piece off and put another one in.
Yeah, Legos is a good one.
Yeah. And so it's a huge improvement for folks, right? But again, the goal for me is let's put it in right the first time.
So I don't have to fool with that.
Right. And so, all the ways we do that, we talked about the imaging. We talked about the 3D planning. We talked about 3D printing, right? Where we get custom stuff. The other stuff that we're doing now is we're using, everybody throws around robotics, and I'm actually on one of the design teams, I've told you about that, where we're working on robotics and we're awfully close, but at the same time, we're not robotics in shoulder replacement is not being done across the board. I mean, there's been none done in the state of Tennessee currently. We're very close. But at the same time, it's not everywhere right now, right? It's not like knee and hip replacement where that is kind of everywhere now. But what we're doing, which is, one step off here, is we're doing a ton of augmented reality and mixed reality. So again, I told you I'd rather be, out in the field or in the mountains or in the river fishing or whatever. But if we are behind a television screen or doing something, again, I'm not a gamer. I think you're a little bit of a gamer, but I'm not much of a gamer. But we use these augmented reality headsets, right? Mm-hmm. And we bring those in the operating room, right? And so I'm able to operate. I guess the analogy I used, and this was one of the guys up at Harvard that's a colleague of mine that helped design this stuff. He said, think about a fighter pilot, right? If you're landing a gazillion dollar, fighter jet,
sure,
and you're landing on an aircraft carrier, right? You need to see what's going on around you, but you also need real-time feedback being piped in real time into your heads-up display, right?
Sure.
That's telling you approach angles and all these angles and all this stuff, right? You need to be able to have all that data in real time being sent to you, but you also got to know what's happening around you. So that's where augmented reality and shoulder navigation, all those things come into play, is that you have your eye on the patient, you're in the operating room doing the task at hand, replacing the shoulder, but you have all this feedback that you already previously looked at and planned that's in this headset, that's a virtual reality. So I can grab the implant or the shoulder, like, here and say, hey, this is what I'm looking at. And in 3D, I can, snap it, grab it, and bring it over the patient and look at my angles and say, is that perfect? Is that exactly, am I off by 0.5 degree or 1 degree?
Right.
And I have instruments that tell me in real time, you're really close, doc. Hey, Kennon, you're 1 or 2 degrees off. And then I can dial that in, and titrate it to exactly what we want to make it essentially as close to perfect as we can.
Right.
And, so patients ask, well, you used to be able to do this, and studies will tell you, we used to be able to do this within maybe 10 degrees, give or take. And a lot of docs still say, well, 10 degrees is pretty good, right? And I'm like, well, maybe.
But what if you could do better?
What if you could do better, right? And ultimately, what it comes down to is whenever we have new technology, we have to decide, is it worth the time and the energy to give our patients not just a good outcome, but a great outcome, right? Mm-hmm. And so for me as a surgeon, you as a physician assistant and an associate and being in the OR with us, we have to decide, is it worth it for us to take that time, energy, money, late nights, early mornings, right? In order to give the patient not just an okay outcome, but really give them a great outcome. And for me, the answer is yes, right?
For sure.
So I'm
100%.
not a lazy guy. I love giving patients the best absolute outcome we can give them. And so for me, I think that's where the technology comes into it, both on the operative and non-operative side, and really trying to do what's absolute best for each patient,
That's the goal.
Yeah, I agree. So hopefully it's been educational. I think it's fun kind of cutting up and talking about some of the new stuff. But yeah, hopefully this helps folks out there understand kind of what's going on and what their options are, and understanding things are not the way they used to be. So if you're not using the technology and not using the resources available to you, you're behind, and again, not a tech guy, not a gamer, but we got to use the technology that's out there to give patients a phenomenal outcome. So sounds good.
Yeah.
All right, guys.